Hi, good evening. This is In the Public Interest. My name is Linda Johnson, and my guest this evening is Dr. Charles B. Simone of the Simone Protective Cancer Institute. Welcome, Dr. Simone.
Thank you, Linda.
I know you've been a regular on here. I love having Dr. Simone, but especially today, March 18th. This is March, and March is National Colorectal Cancer Awareness Month. And we're going to talk a little bit about some of the issues surrounding colorectal cancer. As far, and I know how you are. We're going to talk about prevention.
Right.
And some of the things that we need to do ourselves as far as getting screened and tested.
That's right.
So let me just start off with a general question. I'm a woman, you're a man. Am I just at the is the risk the same
Pretty
for
much.
male or female?
It pretty much is, yes. It's not related to gender at all, but rather the fact that what we eat is pretty much what's responsible for it.
So are there certain factors? How do I know if I, as a person, am at risk for colorectal cancer?
Well, first of all, the number of colon cancer cases in our country is about 110,000 per year, new cases. And about 50,000 people die every year from colon cancer. When you look at the whole world, it's about 1 million new cases a year, and about 500,000 people die of that disease every year. So the numbers are enormous around the world and even in this country. Generally, people present to the doctor when they have some rectal bleeding, red blood, sometimes black stool will occur, but usually red blood, or there's some pain and cramping, or even the stool changes the shape. That is, it becomes more narrow. Wider sometimes and then more narrow again. So changing shape, changing color, and some pain are indicators of symptoms of this problem.
Now, we just recently did a kickoff for National Colorectal Cancer Awareness Month through the New Jersey Seed program here in Mercer County. And one of the issues came up about inflammatory bowel disease. Is that a risk factor for colorectal cancer?
It is. Inflammatory bowel disease is a general umbrella term that includes things like Crohn's disease and ulcerative colitis. Ulcerative colitis is a little more dangerous than Crohn's with respect to risk of cancer. In fact, the risk of cancer goes up by 1% per year of having ulcerative colitis. You must treat aggressively the ulcerative colitis with surgical removal of the inflamed area.
Okay, we all have been going back and forth, I know, with the New Jersey Seed program about screening. And I want to touch on that just a little bit. Trust me, I ask you, I ask Dr. A, Dr. B, I'm just putting it all together. Are there screening guidelines? What kind of screening should I have?
Well, the best screening for everybody around is to go to a drugstore and buy an all-called blood test. In other words, you can go and say, I want a little kit so I can test my stool for blood. It's very simple to do. You get a little smear of the stool from the toilet tissue, smear it onto this little slide that they provide in the kit, and you'll find out whether you have blood in your stool or not that you can't see. If there is blood that you obviously can't see, then you need to attend to that and see a physician for it. That's the easiest thing to do and wide open to everybody around the country. That's what everyone should do. The next best thing is to also, once you have symptoms or after a certain age in this country, you should have a screening colonoscopy. And that's done relatively easily. There are lots of colonoscopy doctors around. It's done with some light sedation these days. In the old days, it wasn't, but some light sedation. And the colonoscopy doctor will look into the colon from the anus all the way to, hopefully, the cecum, a whole range of many feet of colon to see if there's any polyps or any areas that look like a cancer. And then report back, take a biopsy of it, and look back at it.
Now, I recently read some facts that said colorectal cancer behind lung, and I always tell people this, please stop smoking, is the second leading cancer killer in the U.S. And I know you're talking about colonoscopy and the whole thing, but what's the age and what's the difference? I'm asking you a lot here between sigmoidoscopy, colonoscopy. I've heard all these terms.
A sigmoidoscopy is a procedure where you don't need to do lots of preparation for it. You can go into an office setting, and a sigmoidoscopy goes from the anus up into about 1.5 feet long. So relatively short distance, but in that short distance, you can get and see about 50% of all the cancers we know about. So in a short period of time, in a very low-cost setting in the office, you can see most of the cancers that we're going to see, half of them. A more extensive colonoscopy should be done for high-risk patients. Now, when should it be done? After the age of 50 in most people. African Americans probably should start a little sooner.
Now, what about barium enemas? I've heard about that, too, as a possible screening tool. Are they effective?
They are. When you go and look at the studies at colonoscopy versus barium enema, colonoscopy is probably a little more sensitive at finding things, and a little better because if you do see something, you can actually biopsy it, bring it back to the lab, and take a look at it under a microscope.
Now, I'm going to put you on the spot because I know we didn't get the chance to talk about this, but there's the colonoscopy, and now there's something new called the virtual colonoscopy. Can you shed a little light on the difference?
Shed a little light. That's very good, Linda. Well, there are studies to show that the virtual colonoscopy is a very effective tool, but I think it's an early stage situation. There are studies out there with large numbers of people, but I think it's an early stage situation. We need to have a little more time. Because those virtual colonoscopies may miss a little polyp behind a valve that can't be seen otherwise.
Now, you've mentioned polyps a couple times, and I really want to bring attention to that because there are some people who have a predisposition to polyps, and is it true that not all polyps are cancerous?
That's right.
But if you have a polyp, we need to have it removed, correct?
Absolutely. All polyps that are seen should be removed if they can be removed. If they can't be removed easily by the colonoscopy doctor with a colonoscopy, then they need to be removed from a surgical standpoint. But that's a little technical and a little detailed. The key thing is we can prevent polyps. We can prevent them with simple two little things. Well, several things. Aspirin. If you take aspirin every day, at around 6 p.m. at night, that's when you should take it. 325 milligrams, the old-fashioned dose, that's what you should be doing. That will help prevent polyps. And calcium. Not many people in our country take calcium, but calcium carbonate is a very effective way of preventing colon polyps. Now, polyps can proceed to cancer, so if you prevent the polyp, you prevent the cancer.
Understand. So it's like chicken or the egg. So
well, you want the chicken and the eggs all the time. But also a high-fiber diet. Most Americans do not eat a high-fiber diet. We typically eat about 5 grams of fiber a day, and what we need is about 35 grams of fiber a day. And that brings us to the Bantu tribesmen in Africa. The Bantu tribesmen in Africa are people who consume a lot of fiber, tremendous amount of fiber, so much fiber that they produce stool about 7 inches high every day. Now, there's not 5 people in this room that can produce stool that amount per day.
You're right.
That's right. So the higher the fiber, these people, by the way, have very low rates of colon cancer, prostate cancer, heart disease, and cancer in general. The higher the fiber, it's been shown by Dennis Burkitt, Dr. Dennis Burkitt, the higher the fiber intake, the lower the risk of colon cancer specifically, and many other cancers as well. The reason is this. Fiber goes in, and there are 2 kinds of fiber, and this is important to look at. The soluble fiber gets into the GI tract, gets into the bloodstream, attaches to it with cholesterol, triglycerides, etc., brings it back to the colon, and washes it out. The insoluble fiber, and I'll tell you what these are in a minute. The insoluble fiber is like a little rotor-rooter, a little sandpaper. It goes into the GI tract, stays gets into the GI tract, gets into the bloodstream, attaches to it with cholesterol, triglycerides, etc., brings it back to the colon, and washes it out. The insoluble fiber, and I'll tell you what these are in a minute. The insoluble fiber is like a little rotor-rooter, a little sandpaper. It goes into the GI tract, stays in the GI tract, and keeps sanding off the layer of the colon. So you want both types of fiber all the time. Now, soluble fibers, they're important to know. They're things like gums or apple skin, pectins. Gums are very important. We have them. Usages, psyllium. These are things we have all the time. Oatmeal, tremendously high in psyllium. So we need those soluble fibers. But we also need the insoluble. Like every other fruit and vegetable you can think of has insoluble fibers. So we need a combination of fruits and vegetables and grains to help clean out sandpaper off the inside of the colon, as well as get into the bloodstream as well.
It's a little bit like a rotor-rooter type of thing.
Yep, natural way.
Now, that was very